This is part 3 of our Lp(a) series, and we are going to talk about the entire pipeline of drugs for Lp(a) that is coming down the pike. What they are, how they work, why we believe they should work, why we still have some reason to be cautious, and then a 5-step framework for how I want you to think about it. By the end, you'll know exactly where this Lp(a) pipeline stands today, what questions are still unanswered, and how to decide whether these might make sense for you once they arrive. Hi, if you're new here, I'm Dr. Lily Johnston. I'm a board-certified vascular surgeon and also a specialist in cardiometabolic prevention and wellness. Let's get right into it. Let's start with the mechanism. These drugs all prevent the production or synthesis of Lp(a) right in the liver. And this is technically kind of new because even though the statin drug works by inhibiting the enzyme responsible for cholesterol synthesis, truthfully, the big impact of statins is by upregulating the LDL receptor in the liver and pulling more of those ApoB particles out of circulation. So this idea of actually stopping synthesis completely at the root is a novel mechanism. And one of the really brilliant things about these new drugs was how they were targeted specifically to the liver, which means they can be more potent at a reduced dose and very, very targeted. And that little molecule is called GalNAc, and you can think of it like a zip code. It's a little address label on these injectable medications that is really only taken up by the hepatocytes or those liver cells. And so all of these drugs are just entirely preferentially taken up by the liver and have minimal, if any, off-target effects in other organs. So now let's talk about the individual classes of medications that are in the pipeline, how they all work, and where we are today with their pivotal trials. The first are the antisense oligonucleotides, and there's really only one in this category. That's Pelacarsen. The antisense oligonucleotide is a strand that mimics the mRNA sequence of the protein, the lipoprotein a that is synthesized, and it sticks to it so that that mRNA sequence cannot be read by the ribosome and the protein cannot then be synthesized. Every antisense oligonucleotide that is injected gets stuck once to the mRNA and then is used up. Pelacarsen has the GalNAc zip code tag that we talked about. So again, it is preferentially taken up almost exclusively by those hepatocytes in the liver, and it does all its work there. The phase 2 results were already published in 2020 in the New England Journal of Medicine, and this was the phase 2 Lp(a) Horizon. They showed a dose-dependent reduction in Lp(a), anywhere from about 35% all the way up to 80% in the highest doses. And the other thing that was really interesting about this phase 2 trial was that they measured oxidized phospholipids as well and showed a dramatic reduction. If you'll remember from part 2, we talked about the fact that lipoprotein a carries kind of a disproportionately large amount of these oxidized phospholipids, which are very inflammatory, very sticky in the artery wall, and probably account for a lot of the excess risk that is conferred by lipoprotein a. So even though it's very intuitive that oxidized phospholipids would go down as Lp(a) goes down, again, it's really nice to have this demonstrated with real data in this trial. So Lp(a) goes down in a dose-dependent fashion, as does the oxidized phospholipid content. Excitingly, Pelacarsen is in phase 3, and that has completed its recruitment. So that trial is already underway. There are about 8,000 patients in this phase 3 study, all of whom have established atherosclerotic cardiovascular disease, or ASCVD, and elevated Lp(a). And the threshold for that trial is approximately 70 milligrams per deciliter. So you'll remember 50 is kind of the cutoff for high, 70 is what they're using in this trial. And you'll see as a theme throughout that all of these trials, patients are going to be pretty squarely in that elevated risk bucket. This is a monthly injection. They're going to use the 80 milligram dose, and they determine that from the phase 2 versus placebo, plus guideline-directed therapy for patients with ASCVD. The primary endpoint of this trial is a composite or a combined endpoint that includes cardiovascular death, heart attack, stroke, and urgent coronary revascularization, either with a stent or a coronary bypass procedure. And Originally, trial data were expected in 2025. Obviously, we don't have that quite yet, but we do expect hopefully the readout of this in 2026, and I would expect that to be featured at one of the big cardiology meetings coming up next year. In terms of safety, again, we have good news here. Patients report some injection site reactions, redness, itching, but we don't have any indication yet of major side effects or any big safety concerns with this trial. So that's very exciting. All right. The next class of medications we're going to talk about are these small interfering RNAs. Now, these sound a lot like antisense oligonucleotides insofar as they do also prevent the synthesis of the lipoprotein a protein, but they do it in a little bit of a different way because they hijack a mechanism called the RNA-inducing silencing complex. And what this means and why it's important is that these small interfering RNAs can be recycled. We can use them over and over and over again instead of just one time like we can with the ASOs. So that means the half-life is longer. We have less frequent dosing schedules for these small interfering RNAs, and there are 3 of them that are under investigation right now. The first of these, which is furthest along in the trial process, is called Olpasiran. This is manufactured by Amgen, and it is part of the Ocean A trial. So in phase 2, and we'll show you a figure, we had greater than 95% LPA reduction at the 75 milligram dose or higher every 12 weeks. That is an incredible lowering of that LP little a level and every 12 weeks. So that's a quarterly injection. And again, safety signals, nothing overly concerning so far. Again, with injection site reactions, some hypersensitivity. But if you're looking specifically for some of the side effects that we see in other ApoB therapies, like myalgia or muscle pain, it was equivalent to placebo. Any new onset diabetes or problems with blood sugar, also equivalent to placebo in the small phase 2 trial. Again, Ocean A now is in phase 3 in the outcomes trial, and they have completed enrollment for that. They have about 7,300 patients enrolled, all of whom have established atherosclerotic cardiovascular disease and Lp(a) greater than 200 nanomoles per liter. So this is a quarterly injection versus placebo, and the primary endpoint is very similar to the LPA Horizon. It is a composite endpoint of time to cardiac death, heart attack, or urgent coronary revascularization. And we expect results in December of 2026. So we're looking at major pivotal trial results for 2 of these molecules in the next year. The third agent we'll talk about is Lepodisiran. This is manufactured by Eli Lilly, and the Alpaca was the phase 2 trial. They had a single 400 milligram subcutaneous dose that demonstrated a 94% reduction in Lp(a) from baseline. And if you got 2 doses, one at a baseline time point and one at 6 months, we saw a 91% reduction at 1 year. So 2 injections and your Lp(a) goes down by over 90% for an entire year. That is truly incredible and very remarkable. And again, injection site reactions, and a few patients had elevation in their liver enzyme markers, but no patients discontinued participation in the trial related to adverse events. So best we can tell so far, these are all very safe drugs. Now, Lepodisiran is the one of these that is actually enrolling actively for the phase 3 trial. So if you are a patient with elevated Lp(a) and you really want to be in a clinical trial to help with the research in this and potentially get exposure to one of these treatment agents, this is the one that is currently enrolling. They are planning for 16,000 patients, and LPA threshold is 175 nanomoles per liter. Now, they're going to split this into 2 separate arms of the trial, and this one is also really interesting for another reason. They will absolutely have a regular secondary prevention arm. Those are patients who have already had things like heart attack or revascularization, but there is a second arm in this trial, and it's what I would call secondary prevention light, what other people would call high-risk primary prevention. These are going to be patients who have known plaque or very high-risk features like concomitant familial hypercholesterolemia, but have not yet had a cardiac event or a stroke. So the goal is going to be to see whether we can prevent a first event in these very high-risk patients. Again, very similar primary endpoint, time to cardiac death, heart attack, stroke, or urgent coronary revascularization. Because this is still ongoing, you can imagine it will take us a few more years to get those data out. We expect 2029, maybe 2030. And the last of these in the small interfering RNA class is called Zerlasiran. We have very similar phase 2 results in their phase 2 trial, which was called Alpacar 360. That was dosed every 3 weeks. I won't recapitulate all of the same things. What I will say is they don't yet have a phase 3 trial. This was a small company and they were awaiting a development partner before engaging in a very costly, much bigger phase 3 trial. So stay tuned to see if Zerlasiran will also come into phase 3 in the next year or two. Last big mechanism we're going to talk about, and it's different, and it's also an oral pill. It's not an injection. So this is pretty neat for anybody who is very needle phobic. This is called an oral assembly inhibitor, and Muvalaplin is its miserable generic name. It is also manufactured by Eli Lilly. And what it does is it prevents the ApoA tail molecule from attaching to the ApoB lipoprotein. So if you'll remember, and we'll show you a picture here of the structure of that lipoprotein little a whole molecule, it's essentially a big ApoB molecule, which looks kind of like an LDL particle. And then it has this ApoA tail on it. So it prevents the attachment of that tail to ApoB. And in a small phase 2 study, they showed up to 70% reduction by a traditional assay. And interestingly, they actually invented a new assay to measure Lp(a), and they showed an 85% reduction by this new intact Lp(a) assay with one daily pill. There were no significant adverse events in that trial, but it was only 12 weeks, so very short study and no suggestion about when they will potentially begin enrolling for phase 3 yet. So I want to talk for a minute about why it's very intuitive that this should work, that these medications that dramatically reduce these Lp(a) levels really ought to result in exactly what we think, which is dramatically reduced heart attack, stroke, and even limb loss for patients who have very high Lp(a). And the most obvious reason is we actually already have a proof of concept. And again, in our part 2 video, we talked about the use of plasmapheresis, which is a dialysis-like process where blood is removed from the body, cycled through a machine that specifically takes out all of the ApoB particles, including Lp(a), and then returns the cleaned blood back to the patient. And in those patients, we absolutely see an improvement in their clinical outcomes after plasmapheresis. And it is the mainstay of treatment for our patients with the most severe disease. But it also clears all ApoB particles. So we don't know for sure what is due to the Lp(a) specifically and what is due to ApoB. Above that and beyond, we also know that plasmapheresis clears some other things. It clears some inflammatory markers and some clotting factors. Plasmapheresis reduces blood viscosity. It even improves endothelial function. We can see improved vasodilation, which is basically part of the nitric oxide pathway, after one session of plasmapheresis. The last thing that's pretty different about plasmapheresis versus these medications is the kinetics of what Lp(a) is doing in the body. So when you get plasmapheresis, your Lp(a) levels will tank, but then the cleaning process is over, and so they will steadily rise back up to your baseline until your next plasmapheresis session. So there's this pulsed effect. And ultimately, even though that means it's very effective at reducing Lp(a) at the time of your plasmapheresis, overall, you're still getting more exposure than you would from these drugs that are tanking your Lp(a) levels, but keeping it at that really low bottom basement baseline. So we don't know if the kinetics of this will also change how people respond to very low levels of Lp(a). And the last thing I'll say about plasmapheresis and why it's not a perfect model for why we believe these drugs will work, it's never been randomized. So, we use it as this salvage modality, and the, observational data are very compelling. Patients really do better after the plasmapheresis than before. And if you compare cohorts, again, it's pretty compelling. But just to be clear, it has never gone through a randomized controlled trial. So for all those reasons, these phase 3 trials that are going on with Lp(a) are super important for us to understand exactly what's going to happen. And even more, we're going to talk about a few examples of drugs in the cardiovascular space that everybody thought were going to be total blockbuster agents. Like everybody knew these were just going to be game-changing for cardiovascular patients. And they were not. They instead went the way of blockbuster movie rentals. The first one of these was the class of drugs called the CETP inhibitors. Now, these were all based around the HDL story, right? This idea that patients with low HDL cholesterol are at higher risk for cardiovascular events, and higher HDL tends to be protective, probably due to good functional reverse cholesterol transport, getting that oxidized phospholipid out of the cell wall and taking that those cholesterol molecules away. But we have never proven, in fact, that raising HDL would do any good for patients. And the CETP inhibitors were unfortunately a cautionary tale because we had no fewer than 4 different CETP inhibitors, and 0 of them ever made it to market. One of them had really bad off-target effects, meaning it did stuff it wasn't supposed to do, and hurt patients. They had elevated blood pressure and really severe adverse events, so that was canned. 2 of them had pretty good results improving HDL, but no impact on cardiovascular outcomes. No impact. So HDL went up just like we thought it would, and just like it was supposed to, but it didn't change the outcome. The last of these had a very slight improvement in outcomes and still wasn't brought to market because above and beyond standard therapy, it didn't move the needle enough. So the bottom line for CETP inhibitors, the biomarker changed, right? HDL went up. And that's where we are with the Lpa drugs right now. We know the biomarker changes. We know Lpa goes down dramatically with these drugs. But if the outcome doesn't change, then the biomarker doesn't matter. So the CETP inhibitors moved the biomarker and didn't change outcomes. Lpa, stay tuned, okay? If you guys actually are interested and want to learn more about this and you want a dedicated video on the whole CETP inhibitor story, including the new CETP inhibitor that is actually in clinical trials right now, let me know in the comments below. We'll add that to our list. The second of our cautionary tales in cardiovascular drug development is Canakinumab. So this was a drug designed to target the inflammation component of cardiovascular disease. And you guys know I love inflammation. We talk about it a lot on this channel. And the whole idea behind the CANTOS trial and Canakinumab was to suppress the inflammatory signal that drives plaque formation and progression. So this was a monoclonal antibody, so it was an injectable drug against one of the cytokines or the inflammation molecules called interleukin-1 beta. And the interesting thing is that it actually worked. It worked really well. I'll show you a graph here. We had significant reduction in major adverse cardiac events. It was great. Everybody thought, what a success. Just one teensy tiny little problem. And that was that for all the improvement we saw in cardiac events, we had an increase in fatal infections. So perhaps suppressing the immune system without getting to the root cause of why our bodies are inflamed is not actually as good an idea as it sounds like out the gate. So overall, the result of this trial was a net neutral effect on mortality. So people died less of cardiac events and more of infection, and it was even on mortality versus placebo. For a drug that was going to cost tens or hundreds of thousands of dollars a year, guess what? Nobody thought that was a good idea, and that's why you've never heard of Canakinumab. It was canned. So these 2 examples, the Canakinumab example and the CETP inhibitors, all point out that it's really important to understand what happens in these trials for outcomes and what the unintended consequences of these new medications might be. So how do you think about all of these different components? Who's in the trial, what the drug was, what the outcomes were? Well, Let me tell you how I think about it, and you can decide for yourself if that makes sense. Let's walk through the 5 steps I use to make that decision. Step number 1 is the indication. Step number 2 is the evidence. Step number 3 is the patient. Number 4, trade-offs. And the last step is, what would you do? Let's go through those in detail. So step 1, indication. What clinical problem does this medication actually solve? And what is the magnitude of the benefit? How much solving of the problem are we going to get? When we think about the evidence, what I want to know is, how strong is the evidence and is it unbiased? Are there multiple lines of investigation that would support the mechanism? Do we have long-term outcome data? And perhaps, is there any data that was not sponsored by industry, that was not a pivotal trial? And that's not to say that industry-sponsored trials are inherently biased or wrong. They are not. They are absolutely essential for drug development and for progress. And we know that over time, it would be nice to have third-party corroboration of those data that was not industry-sponsored. And if we have that, we feel even better about those outcomes. Step number 3, the patient. So who is the right target for this particular intervention? And this means diving deep into those trial data and figuring out who was included in the trial and who was excluded in the trial. This could be anything like age, sex, but comorbid conditions. Were patients with autoimmune disease eliminated from the trial? Patients with chronic kidney disease, were they included or excluded? What about ethnicity? Did we do a good job recruiting a diverse patient population into the study? What about stage of disease? And this is really important for these cardiovascular trials because there are primary prevention trials. Those are for patients who have not yet had a heart attack, stroke, or limb event. There are also secondary prevention trials, and the prevention sounds funny in this context because they are patients that have already had heart attack, stroke, or limb event, but we are trying to prevent the next one. We are trying to prevent death from any of those problems. So those are secondary prevention trials, and those patient populations behave very differently. And we would expect a longer runway for the primary prevention, shorter for the secondary. So the patient in front of me, are they primary prevention? Are they secondary light, meaning I know they have disease, but they haven't had an event yet? Are they true secondary prevention? I've already done a bypass or put a stent in their leg. All of this really matters when we're thinking about who was represented in the trial, and is that like the patient sitting in front of me? If not, how do we reconcile that? In step 4, we talk about the trade-offs. So this absolutely includes side effects, but it also includes things like the cost, the duration of treatment. Is this a short-term thing, or is this patient expected to be on this medication for life? Are there potential unintended consequences? Are those risks we are willing to tolerate because the clinical problem, the indication, step 1, is so severe? All of this comes into play. And what alternatives might exist? Could we do this with an older medication? Could we do it with a lifestyle intervention? What alternatives do exist for this patient? And step 5 is a summary step. It asks the question, would I take it or would I give it to my mom or my best friend? Because at the end of the day, we're going to sum up all of the first 4 steps and need to answer that very specific question. And honestly, even though not everybody asks me what I would do, I like to know personally whether I would do this for myself or somebody I loved before I make that recommendation. And many patients do ask, and I want to give a very honest and straightforward answer. So that's step 5, summing it all up, would I take it? You guys now know exactly how I think about these new drugs. You know exactly what is coming down the Lp(a) pipeline and why there is reason for both hope and just a touch of skepticism. And if you missed the video on how to manage your high Lp(a) with what is available today, we will link that here. If you found this helpful, please click like and subscribe and send this to somebody who needs to hear it. Until next time, take really good care.